Thank you so much for joining us today for the Q4 FY20 Inpatient Rehabilitation Facility PEPR review. My name is Annie Barnaby. I work for Rely Group, Inc. We are contracted with the Centers for Medicare and Medicaid Services, CMS, to produce and distribute the PEPR reports. Our agenda today, of course, will be to review the Q4 FY20 Inpatient Rehabilitation Facility, IRF, Program for Evaluating Payment Patterns Electronic Report, the PEPR. We will review some other resources, national and state level data, and peer group bar charts. So let's get started. Today's presentation will be a high-level review of the PEPR. So if you're familiar with PEPR, this will be a nice refresher. But if you're new to PEPR, you might still have questions at the end of the session, and we have resources available to you to help if you do have questions. These resources can be accessed through the PEPR website in the IRF Training and Resources section. And our website is pepper.cbrpepper.org. Let's start at the very beginning. What is PEPR? PEPR is an acronym that stands for Program for Evaluating Payment Patterns Electronic Report. A PEPR is a comparative report that summarizes one facility's Medicare claims data statistics for areas that might be at risk for improper Medicare payments, primarily in terms of whether the claim was correctly coded and billed, and whether the treatment provided to the patient was necessary and in accordance with Medicare payment policy. In the PEPR, these areas that might be at risk are called target areas. The PEPR summarizes your facility's Medicare claims data statistics for these target areas and compares your statistics with aggregate Medicare data of other facilities in 3 comparison groups. These comparison groups are all the hospitals in the nation, all facilities that are in your Medicare Administrative Contractor or MAC jurisdiction, and all facilities that are in the state. These comparisons are the first step in helping to identify where your claims could be at risk for improper Medicare payments, which in the PEPR world means that your billing practices are different from most other providers in the comparison group. I do want to stress that the PEPR cannot identify improper payments. The PEPR is a summary of your claims data and can help you identify or alert you if your statistics look unusual as compared to your peers. But improper payments can only be confirmed through a review of the documentation in the medical record along with the claim form. Taking a look at the history of the PEPR, we can see that the PEPR began back in 2003. TMF Health Quality Institute developed the program originally for short-term acute care hospitals and later for long-term acute care hospitals. In 2010, TMF began distributing PEPRs to all providers in the nation, and along the way, they developed PEPRs for other provider types, which you can see on the slide here. Each of these PEPRs is customized to the individual provider type with the target areas that are applicable to each setting. Then, in 2018, CMS combined the Comparative Billing Report, or CBR, and the PEPR programs into one contract, and the Rely Group and its partners, TMF and CGS, now produce CBRs and PEPRs. While the CBR program produces reports that summarize Medicare Part B claims data, the PEPRs summarize Medicare Part A claims data. These reports are produced for providers across the spectrum that help educate and alert providers to areas that are prone to improper Medicare payments. Why does CMS feel that these reports are valuable and support their agency goals? Well, CMS is mandated by law to protect the Medicare Trust Fund from fraud, waste, and abuse. And they employ several strategies to meet this goal, such as data analysis activities, provider education, and early detection through medical review, which might be conducted by the Medicare administrative contractor, a recovery auditor, or some other federal contractor. The provision of PEPRs to providers supports these strategies. The PEPR is considered an educational tool that can help providers identify where they could be at a higher risk for improper payments. The providers can proactively monitor and take preventative measures if necessary. I should also mention that the Office of Inspector General, or OIG, encourages providers to have a compliance program in place to help protect their operations from fraud and abuse. An important piece of that compliance program is conducting regular audits to ensure that charges for Medicare services are correctly documented and billed, and that those services are reasonable and necessary. The PEPR supports that auditing and monitoring component of a compliance program. Now that we have a sense of the history of the PEPR program and why it was created, let's talk specifically about the newest release of PEPR, Q4 FY20. Again, the PEPR only summarizes Medicare fee-for-service Part A claims data and does not include any other payer types such as Medicare Advantage claims. Every time that a PEPR is produced and released, the statistics are refreshed through the paid claims database. Therefore, if you're looking at a previous PEPR release and comparing it to this release, you probably are going to see some slight changes in your numerator denominator, your percentile, those types of things. That could be because there are late claims that are submitted or corrected claims, which would be reflected in the updated statistics. Anytime we produce a report, the oldest fiscal year rolls off as we add the new fiscal year. Let's talk now about the improper payment risks that are pertinent to inpatient rehabilitation facilities. IRFs are reimbursed through the IRF Prospective Payment System, or PPS. The primary risk that we focus on in the PEPR relates to coding errors and unnecessary admissions. IRFs are at risk for both of those situations. Those of you who have been working with PEPR for a long time know that there have been some changes in these target areas over the year, and some significant since we first started producing the reports in 2003. The original target areas were identified primarily from information gained through review of the IRF, PPS, coordination with CMS IRF subject matter experts, and analysis of national claims data. The target areas are evaluated every year so that we can ensure that all target areas included in the report remain applicable and beneficial. As new risks are identified by recovery auditors or Medicare administrative contractors, or as policy changes are implemented, the target areas change to accommodate those risks. The target areas within the PEPR pertain to a service or a type of care that's been identified as prone to improper Medicare payments. We construct these target areas as ratios, where the numerator is a count of discharges that could be problematic, and the denominator is a larger reference group that also includes the same numerator discharges. This calculation allows us to calculate a target area percent, and we'll talk about target area percents here in just a minute. Here you can see the IRF PEPR target areas. Those are those areas that are prone to improper Medicare payments, that are at risk for improper Medicare payments. Those last two target areas listed, the 3 to 5 stay readmissions and the short stays are relatively new. They were introduced in the previous release, Q4 FY19. How do percentiles work in the PEPR? Well, this slide can help us to understand how the percentiles are calculated with the percents. The ladder image is a great representation of how we do that. Next to the ladder is a list of the target area percents sorted from highest to lowest. So those percents that you see listed there are going to be the outcomes for each facility for each target area. The first step our team takes when we calculate your facility's percentile is to take all of these target area percents for a specific target area and a specific time period. We take the target area percents for all the facilities in the nation, and we sort them from highest to lowest, and that is what the ladder represents. You can see the percents listed from highest to lowest down the ladder. Next, we look at that list of those percent outcomes, and we identify the point below which 80% of those outcomes fall. And that point is identified as the 80th percentile. You can see it marked there on the ladder image. So any facilities that have a target area percent outcome that is at or above the national 80th percentile will be identified in the PEPR as a high outlier. A high outlier is identified in the PEPR target area tab data by red bold font. Now, a high outlier outcome could potentially mean overcoding, or it could just mean that your statistics look different for another justifiable reason. These percentiles are a good way to get some context and think about how our target area percent compares to the other facilities in the nation or in the jurisdiction or in the state. This context can help us think about whether that difference is what we expect to see or if there's something that perhaps we should be concerned with. I'm going to go to the sample PEPR now so we can see in an actual document how all of this data is presented. Let me get to our first tab here on the PEPR. You can see this tab is labeled Purpose, and that is what the tab represents. It gives information about the PEPR program. It identifies the hospital by their hospital number. It tells you the jurisdiction that the hospital falls under, and again, it lets us know that this is the IRF PEPR version Q4 FY20. You can see along the bottom here, the PEPR is separated by these tabs, and of course each tab serves a purpose, and the next tab is a tab that is full of really beneficial information. And we just talked about how we calculate the percent outcomes for the hospitals within the PEPR. And this tab gives you information about what data is included in the numerator and the denominator for each of those calculations for each of the target areas. So if you're in a target area and you suddenly wonder, wait a minute, what am I looking at? What type of information is included in these numbers that I'm seeing in this data and these results for my facility? You can go back to the Definitions tab and take a look, and it will have all the information that you need. So it's a handy little guide that's built right into the PEPR. The Compare tab is next, and this Compare tab reports statistics for target areas that have reportable data. Now, for this PEPR, reportable data stands for 11 or more target discharges. So any target area that does not have that 11 or more target discharges is not going to be included in the PEPR. That's the minimum target area discharges, so that would be, again, in the numerator. That's the minimum that we've set for the most recent time period. So that's just something to keep in mind when we're looking at the Compare tab and also when we're looking at these other tabs that represent each target area. You can see here the target areas are listed down the left-hand side there. Let's just take a look at miscellaneous CMGs, case mix groups. The number of target discharges, again, that's going to be your numerator, right? That is 91. The percent outcome for this facility is 13.8%. The facility national percentile, so on that ladder where this facility landed, was at 54.1%. In the jurisdiction, it was 45.8, and then in the state, you can see it was 42.9. So this is a grand overview of the data for that specific target area outcome. And we do go into more detail, and we'll get to that when we get to the miscellaneous CMG tab for that target area. But this gives an overall view. It's a big step back before we go into the detail and all of the data that's presented in each of the target area tabs. You can see line 17, the STACH admissions following the IRF discharge. If we look at the percent outcome for that target area for this facility, it is in that red bold font. So we can know that this facility for that target area is an outlier. They are a high outlier. They are above the 80th percentile. And if you go to that next column, you can see why. That facility national percentile was at 81.8. The jurisdiction, 75.3, the state, 75.9. So those are, again, the outcomes that where this facility fell on that ladder, whichever rung those belonged to, and wherever those fell on that ladder, that was above that 80th percentile line that we draw across those outcomes. Let's take a look at that target area. After we move from the purpose and the definitions in the Compare tab, these next tabs are the target area information and the data for each target area. Now, each of them are set up in the same way. They are formatted in the same way. We have your facility outcome and data that goes into that calculation. We have that in chart form here. And let's take a look at that first. So for this target area, we can see that this facility is not an outlier. And at quick glance, we could see that anyway because there's no red bold font listed on this target area tab. Moving down that chart, the target area percent, you can see their percent outcome, this facility's percent outcome, where they are on that rung of the ladder. And then the PEPR breaks down that calculation for you. The target count, which of course would be the numerator, and then the denominator count. So we give you all the information. We want to be, of course, transparent with the data that we're using for these calculations. And so it's listed here on each of the tabs for each of the target areas. The average length of stay for the numerator, that is looking at the information that is included in the numerator for this target area. For that data, what's the average length of stay? And then, of course, we do that for the denominator as well. And for the target average payment and then the target sum of payments, we're looking at the numerator count of course, for the average payment for the numerator, and then the sum of payments for the numerator. Next, we have the comparative data for the facility in chart form. We're going to look at where that national 80th percentile is. Where was that line drawn in that list of percent outcomes? Well, in FY 2018, that line was drawn at 19.2%. It moved to 19.9% in FY 2019, and then in FY 2020, it actually dropped down a little bit to almost 18%. The jurisdiction and the state percentiles are listed there as well, and you can see where that black line, where that 80th percentile line was drawn for the jurisdiction and the state for each of the fiscal years. Underneath that, we have a graph that shows us the information that we've just looked at in chart form, in graph form. Everyone learns differently, everyone processes information differently, and we want to make sure that everything that we're looking at is clear to everyone possible, as beneficial as possible to everyone. That's why we provide this graph. You can see from the legend, the graph legend, the facility information that we saw up here in the top chart is reflected in these blue bars. The line graph information is the facility information. Then the national 80th percentile is this straight, unbroken line. The jurisdiction 80th percentile is a dashed line, and it was so very close to the state 80th percentile that they're almost on top of each other, but that state 80th percentile line is marked with those dots. Not only in the PEPR do we provide for each of the target areas all of the information that we just went through, but we also include suggested interventions. If I'm a high outlier, what should I do? Listed here. If you are a high outlier, if you see that red bold font for this target area, this could indicate that there are unnecessary admissions for patients admitted in the miscellaneous CMGs. Sample some medical records, review those, determine if the inpatient admission was necessary. We give you that information because we want you to use the PEPR, and we know that it can be a little overwhelming. This is a lot of information, of course. We provide those suggested interventions so that you can take the PEPR and use that internally to review your billing patterns and see if there's anything that you need to be concerned about. As we move along the tabs, we can see each of the target areas, again, is represented with a different tab. And this is a good example of a target area that did not have that 11 or more threshold in the numerator count for fiscal years 2018 and 2019. You can see that's blank data. If you see blank spots in your PEPR, there's nothing wrong and there's nothing missing, you didn't do anything wrong, and there's not an error in the report. It's simply because that numerator, denominator, or numerator count is less than 11. So that's suppressed data for the 2018 and 2019. But we do have results for 2020. And I wanted to take a look at that with you to see what it looks like when that 11 threshold is not met. Outlier payments target area, no red bold font here. Here we see that red bold font in that first chart for FY 2020. This is the target area short-term acute care hospital admissions following an IRF discharge. The outcome percent for this facility did stay about the same in all 3 years. However, in 2020, that 15.5% fell above that 80th percentile line. So they are identified as a high outlier. We're provided with the same information that we saw on the CMG tab that we went through, target area that we went through. We can see here, if we're going to compare those national percentiles, the national 80th percentile, FY 2018, this facility's target area percent outcome was 15.2. That was right at the 80th percentile. So I'm assuming that there are some other numbers following that too that are probably put this facility underneath that 80th percentile in FY 2018. 15.4 was the 80th percentile mark in 2019. Of course, they're well below that. And then right here we can see FY 2020, that 80th percentile line is drawn at the outcome of 15.3%. And their outcome percent was 15.5. So it is highlighted, it is in red bold font. And we can see the same information down here. The facility's outcomes, the national percentile, jurisdiction, and state 80th percentile. And we can see right here, it dips just below where the facility landed. We have a high outlier for this target area. We were in that 80th percentile. What should we do? Well, again, the suggested interventions are here for you. This could indicate that patients are not medically stable or prepared for discharge. The facility may wish to ensure that patient discharge planning is initiated early during patient admission and that patients and their families are prepared to handle patient care following discharge. You might, again, look at your data and find that something looks amiss, something needs to be looked into, and that is, as it's listed, simply a suggested intervention as to the data internally that you might want to review when you're looking at your PEPR and you're using this information to improve your billing practices. We can see no data here for this one, but we know not to panic here because that it would be less than 11. Short stays, we don't have any outlier status here. Okay, so this next tab, top CMGs, you can see them listed here, the CMG number and then the description. This is, again, more data that we provide for you for national data, how you compare, where you fall. And for this tab, it is the top CMGs. So they are listed here. You have the total discharges, the proportion of discharges for each CMG to total discharges, and then the facility average length of stay for the CMG. Those are listed for you. Those are national data for the most recent fiscal year. Jurisdiction, CMGs, same information. This tab lists the tier level information, comorbidity information, as it relates to the number of discharges, the proportion of all discharges. So again, we do have this 11 discharges here, but this is just another section of information that we provide so that you can get all the PEPR data that you need. And then we have it at the jurisdiction level as well. Before we go back to the slides officially, I would like to take a look at our homepage. Our homepage has a wealth of information. There are a lot of links here that can help you, and there are a lot of resources that can help you. We, of course, have information about the PEPR, training and resources, which I'll go to in just a second here. The data, there's a lot of information, a lot of tabs there with the data information that we use for the peppers, frequently asked questions, and then help contact us. That's where our help desk is located. We'll take a look at that in our slides in just a moment. But we do have the Pepper portal, which is perhaps one of the most important pages on our homepage. We have that right front and center so that it's easily found, because this is where you're going to go when you download your Pepper. And there are instructions listed on our homepage on this distribution schedule. And I will go through some information about your validation code here in just a moment as well. But that information is also listed here. Everything is just a click away. So don't be afraid to go to that homepage and find your facility type and click to see where you can get that information about your Pepper and about how to navigate the portal. On the portal, you are asked to provide your information, the provider information. And again, we'll go over the CMS certification number and the validation code information. But I wanted to look first at this section down here. We do have a listing of positions within the organization that we ask you to check which position you hold within the organization. If you don't see your position listed here, I don't want that to dissuade you from downloading your Pepper. If you have the authority to make decisions and you have the authority to download this Pepper, then you can check the box for the title that best describes your position and your responsibilities at that facility. So I just wanted to touch on that because I don't want anyone to kind of stop in their tracks when they see this and think, well, I have to be one of these people or one of these positions to get the Pepper. The Pepper can be shared within your facility as you deem appropriate, and that doesn't always mean that someone within one of these positions is the one that goes to download the Pepper. So just click the one that best describes what you do at the facility. How does Pepper apply to providers? The Pepper can help a facility to identify areas where they may be outliers, as we just saw, and if that outlier status is something that should prompt an internal review within the target areas. We often get questions, do I have to use my Pepper, and do I need to take any action in response to my Pepper? The answers to those questions is no. You're not required to use your Pepper, though it is helpful information, and we encourage you to at least download it and take a look. You are not required to take any action. However, it is important to remember that other federal contractors are also looking through the entire Medicare claims database. They might be looking for providers that could benefit from some focused education or maybe even a record review. And so from your perspective, it would be nice to know if your statistics look different from others, so then you can decide if there's something to be concerned about and if you need to take a closer look, or if what you're looking at is what you expect to see in your Pepper. The Peppers are distributed in electronic format in a Microsoft Excel workbook, and they are available for 2 years from the original release date. We cannot send Pepper through email because of the sensitive data housed within the Pepper. We have to be judicial in the way that we distribute the Pepper, and it cannot be sent through unsecured emails. With this in mind, we do have the online portal that we just saw that you can use to access your Pepper. We encourage you, of course, to go to the portal, download your Pepper so that you can have it in your files for your use. That way you only have to visit the portal once and you have it saved so that you can use it as necessary. We saw that you will need to enter some information to access your PEPR through the portal. First, you'll be asked to enter your 6-digit CMS certification number, which is also referred to as the provider number or the provider transaction access number, the PTAN. This number is not your tax ID or an NPI number. For freestanding IRFs, that third digit of that number will be a 3. For short term, the third digit is going to be a 0, and for critical access hospitals, the third digit will be a 1. So it's just some extra information to help you if you're trying to locate that 6-digit CMS certification number. The validation code for the PEPR portal does vary a little bit from facility to facility, but for freestanding IRFs, the validation code on that portal access page will be either a patient control number, which is found at form locator 03A on the UB04 claim, or a medical record number found at form locator 03B on the UB04 claim form. For a traditional Medicare Part A fee-for-service patient who received services from July 1st, 2020 through September 30th, 2020. That would be the from or through dates on the claim. And again, you can share that validation code, you can share that PEPR as you deem appropriate. And those validation codes are updated for each release. Now, once you receive your PEPR, and let's say you see a lot of red in there, what should you do? First thing, what you should not do is panic. Remember, outlier status does not necessarily mean that compliance issues exist. By design, 20% of the providers are always going to be identified as an outlier for each of those PEPR target areas. But if you are an outlier, I want you to think about why that might be. Do the statistics in your PEPR reflect what you know, given your operation, your patient population, referral sources, your external healthcare environment, any changes in services or staffing? If you have any concerns, sample some claims. Make sure the documentation in the medical records supports the services that were submitted. Review the claim and ensure it was coded and billed appropriately based upon the documentation in the medical record. The bottom line is to ensure that you're following the best practices, even if you're not an outlier. We saw that we have a number of resources that are available publicly on our website, pepr.cbrpepr.org. Some of those resources is aggregate information at both a national and a state level for the target areas, the top CMGs, and average length of stay by CMG tier and discharge destination. This information is updated each time we have a PEPR release. At the national level, data is available for freestanding IRFs and for IRFs that are distinct part units. We also have peer group bar charts, which are updated, again, on an annual basis. Some time ago, we did have providers who had asked us to make available a comparison that would be applicable to what they would consider their peer group. And so these peer group bar charts enable providers to look at that type of information. We have 3 different categories. We look at size, which is dictated by the number of discharges, location, which is either urban or rural, and ownership type, which would be for-profit or physician-owned, nonprofit or church-owned, or government. We do update the peer group bar charts annually. If you find that you do not agree with how we are representing your IRF's ownership type or location, that information will need to be updated through a CMS. We utilize the CMS provider of services file, and that's maintained by the CMS regional offices, so you'll need to contact them with that update. Here we have an example of a peer group bar chart, and we can see the demographic group that we're looking at here is urban. So that's a location, of course. The target area, CMGs at risk for unnecessary admissions. And we have 20th percentile information, 50th percentile information, and 80th percentile information for this target area for this demographic location, which is the urban location. A number of other resources can be found on the Pepper website. There is the user's guide, the Pepper training sessions, a demonstration Pepper, a spreadsheet that will identify the number of facilities in each of the MAC jurisdictions by total and by state, and some testimonials and success stories. There are some really nice success stories out there, one in particular from a Kentucky hospital that used their Pepper to help them identify undercoding. So be sure to check that out. As always, if you need assistance with Pepper and you don't find the answer you need in the user's guide, please visit the pepper.cbrpepper.org website and click on the Help/Contact Us button, and click on the Help Desk button. Complete the online form and a member of our staff will respond promptly to assist you. Please do not contact any other organizations for assistance with Pepper. Rely Group is contracted with CMS to support providers with obtaining and using Pepper. If you have any questions, please contact us. We are the official source of information on Pepper. Please do not pay a consultant to help you with Pepper. We provide support at no cost to the provider, and not all other organizations are going to be able to provide accurate information on Pepper. The website, we saw the top part of our website. This is the bottom part of our website where we continue scrolling down. You can see the resources that we just talked about on the last slide, 2 slides ago. The resources that are listed, and those resources are available for each of the facility types for which we create a Pepper. So you simply go to your facility type and you have that focused education and resources that you can look at for your specific facility. If you do have any questions, again, please visit our help desk at pepper.cbrpepper.org.